No chat. Okay, great. Thanks for joining. I'm just going to go through this paper. It's called "What Sage Has Got Wrong," and it's by a scientist, biochemist from Pfizer. I think is retired now. He's not a virologist or a doctor or a medic or an epidemiologist, but he does have a lot of life sciences experience, and it's on this website. So the first two things to say is it's not a medical paper and it's not in a medical journal. It's from Lockdown Skeptics, so we have to take that with a pinch of salt. But it raises some interesting points, and the main two things that I think we'll sort of cover as a way of going through it is error number one. It says Sage has made two main mistakes, right? So error number one is immunity, and what is the immunity in the population, and has Sage underestimated that or got that wrong? And error number two is what is the infection fatality rate, and how many people should we expect to be infected if we were looking at that, and how is that calculated? And it actually brings up some really interesting stuff in general about what we know and especially what we don't know, and then we take it from there. The second thing I probably want to say is that there is some how do you make decisions when you don't have all the data, when you're uncertain? So from a medical point of view, from a doctor's point of view, we often make decisions about things all the time when it is very uncertain. For example, you might have a patient who has an unknown medical condition that we don't really know about, that there's no good evidence for, and as a consequence we don't really have the right information to say definitively what the right treatment plan is. And in that particular situation, you can look at lots of different studies. You can also look at the biological data. You can look at the anatomy or the physiology. But ultimately, you have to sort of make a reasonable decision. I think my broadcast has stopped working for some reason. Let's try again. Ah, it's still working. And in that particular situation, you have to err on the caution. And I'll give an example. Okay, so say you have a young man and he has condition X, and this condition X we don't really have a good treatment for, but there is some preliminary data, some studies that say we may be able to do this. On the other hand, we know that if we don't do anything for treatment X, then the outcome is nothing will really happen. I mean, we may be able to treat it, but it's a very low risk condition, and actually we don't know how to treat it, but ultimately it won't make much difference to this person's life. And in that circumstance, you might say, well, here's a paper that suggests we may be able to help, but the risks are quite high and we don't really know what to do about it. And from a pragmatic point of view, you would say, well, from a medical point of view, we wouldn't do anything about that particular condition. Whereas if there was a condition which was going to be fatal without treatment, the level of evidence that you would then apply is going to have a lower threshold, because you'll say, well, we'll try something, because otherwise we don't try anything at all. Then the reality is that this is going to be a high-risk situation. So in any high-risk situation, there is always going to be an element of uncertainty, and in that uncertainty there's going to be mostly doctors erring on the most side of caution, because ultimately what we don't want to do is take a big risk and get it wrong and cause a lot of loss of life. So this is a really good example to sort of look at some of the uncertainty, and what we're looking at is when people talk with real certainty about data that potentially, if they got wrong, would lead to hundreds of thousands of deaths. We need to take that very, very carefully, and that's something to bear in mind as we go through this paper. Okay, so we looked at these two areas, and then so we'll take it bit by bit. So the first thing that it comes up is the statement that it's not been that exceptional a year from a mortality point of view. So this is a direct quote from the paper. So this is our data in the UK. This is some Euromomo data, and you can see that this is the Z-score, which is sort of an average baseline for mortality. And I'm just going to have a nice draw on this, and you can see here is coronavirus. Let's just change that to red. Corona-19. And this is a very big spike. It's a bit too thick to be drawing like this. And we've had similar spikes of flu season here and a flu season here, but this far and away eclipses mortality. So mortality has been particularly high this year, which isn't really debatable. And then we look at excess deaths here, which is interesting. So this is from the ONS data, and we can see that the number we can put to that is about 54,000 deaths, more than we would have otherwise seen based on what's happened over the last 5 years. This is a 5-year average. And that's mostly attributable to COVID, and in that about 5 to 10% will be non-COVID deaths, but about 90% looks like COVID, looking at some of the data that ONS has gone back and looked at the non-COVID deaths as well. So the next thing that the statement is sort of said is, he says the pandemic is effectively over. So this is some graphs just from case numbers, deaths from COVID-19 in the UK, France, Italy, Germany, Ireland and Spain. Quite quiet over a period of July, and looks like most of Europe had a collective quiet period over the summer. And then we can see that Spain particularly had a big increase in mortality. The UK is now up to about 150 deaths per day, and France similarly having another spike, and Germany seeing a rise in cases and deaths, but not as near the magnitude. So again, to say the pandemic is effectively over doesn't really correlate with the deaths. You could say that this isn't as big a spike as we saw back in March, and we'll come back to that right at the end. But certainly, I don't think anyone would agree really that it's over. It may be less in magnitude right now, but that doesn't necessarily mean it's over. And then he sort of makes, again, a very certain statement. Accordingly, the country should be immediately permitted to get back to normal life. Now, I thought this was quite an interesting statement. It's like, well, what actually have we done? How much of us are back to normal life already? So this is from mobile phones data in the UK, and you can see over a period of time. So I'll just show you this graph a bit better. So this is just over the summertime. So lockdown, essentially, there was no restrictions really over the summer. So no restrictions here. And then we did start to have local restrictions over this period. But you can see that not much has changed from baseline. So if you imagine that 0% is what people are normally doing, you can see that people were much more in parks over the summer and outdoor spaces, so a big increase in outdoor spaces. But a persistent remaining increase in people at home. About 10% of people are still at home, or 20% of people who otherwise wouldn't be. And also you can see that workplaces haven't really got better. A slight increase here, but we're still about minus 30% people still working from home and continuing to do so. And transit stations, I mean, similarly, people mostly use transit stations, etc., go to and from work, minus 40%. So normal life, as it were, even with no restrictions, didn't really resume. And that's partly because people have just adapted their own behaviour and they're independent creatures, and partly because as case numbers rising again, businesses and individuals will take a view about bringing themselves and back to work or staying at home. So normal life is a sort of goal that I don't think we have actually even gone back to, despite the lockdown restrictions. And that's another really important point, because people's behaviour is very independent. So he then moves on to looking at these. So basically, these two pie graphs are a summary, I suppose, of what the paper is trying to say. So on this side is the current sage thinking, as he entails, and on this pie chart is his projection, is his suggestion of what the evidence-based reality is, and we'll go back and look at where these assumptions come from. But this is interesting. So currently we think that the sage is saying that about 93% of the population is susceptible, so isn't immune to COVID and can become infected, and 7% so far have been infected, which is essentially based on antibody studies which suggested about 3.4 million people in the country were infected. And we can talk a bit about antibodies, which is quite interesting. And then chart number 2 is with some of these assumptions added in. So he's massively reduced the amount of susceptible from 93% to 28%, and said actually 32% of people have been infected, and we'll have a look at how that calculation was made, and 30% are already immune. And he's also added children in here as taking out of the susceptible population, which I'm not quite sure is accurate. But again, we'll take each of these sort of pie charts in turn. But by this measure, he sort of suggests if you add up all these elements, about 70%, then we've already reached or are reaching herd immunity, and the pandemic is ending. So that is essentially the summary of the conclusion. But we'll look very closely at where these assumptions have come from, and also what that can then tell us about what the current literature and research is around COVID, and is that accurate or not. So it's a good point now. So we talk a lot, let's make the point here, we talk a lot about what IFR is, okay? So we talk about this number here, which is the infection fatality ratio. And what that means is if out of everybody that becomes infected, so the virus goes into them, what percentage of those people will then go on to die? So the calculation is the number of deaths that are due to your infection, obviously, over the total number of people to be infected. I'm just going to close the window because it got a bit cold. So then, and the problem is, obviously, with COVID, is that both of these numbers, if you think about it, are a little bit difficult to actually work out what the accurate value is. So the number of deaths is really difficult to work out, number one, because at the beginning of the pandemic especially, we didn't have access to much testing. So the first problem is you don't have the tests to work out everybody that has COVID. You can look at excess death as a marker. So if you couldn't test everyone and there was undiagnosed COVID, how many extra deaths occurred during the peak of the pandemic other than you'd expect, which may or may not be more accurate, but there's some arguable data inside that. And actually in some groups, like children for example, excess death dropped due to lockdown measures, and in other groups, you know, there may be an increase in access to care from overwhelmed healthcare, for example in Lombardy in Italy, where the system was overwhelmed temporarily. So that's a difficult measure, number one. So there's a lot of uncertainty. The second thing is the number of people infected. Well, that's much harder to work out. We know that we're not accurately testing everybody, and that's almost impossible, and certainly at the beginning of the pandemic was impossible. And there are some small completely closed examples. So for example, the Diamond Princess had about 700 infections. Everybody was tested, about 3,000 passengers and staff on this cruise ship that was quarantined. And we could sort of infer from that we saw the number of people who died, the number of people who were infected, and we could make up an infection fatality ratio from that, which actually was about 4%. But the problem is it was a cruise ship, right? And most of the passengers were elderly, and the average age was about 68, which is much higher than the average age in any given country. So again, it becomes a difficult scenario. And one of the other key things is the IFR depends very much on the person. And what I mean by that is if you're older and have comorbidities and male, and actually you're in a high income setting, your risk of death is very different if you're younger and female in a low income setting and have no comorbidities. And there's a few papers that have looked at how different that is in different settings. So to put a single figure on this is very difficult, especially if you start to extrapolate across multiple areas in the world, and similarly. However, the first sort of thing that we are arguing about or looking at in this paper is what is the IFR of COVID. And the paper decides to use this, 0.23%, which is pretty low, and it's far lower than the range of IFR that we've thought about from the beginning of the pandemic, which is about 0.5% to 1%. Just for comparison, influenza, the ratio is 0.1%. So we're talking about, even at the lowest end of estimates of mortality for an IFR for COVID, it's still 2.5 times higher than flu. But the paper that we talk about here is this paper by John Ioannidis, who's an immunologist from Stanford, and he published this in the Bulletin of the World Health Organization, and it's very interesting. It looks through all of the major antibody studies. So the way that they've worked out the number of people are infected is they've looked at all the antibody studies and said in certain populations, for example in New York, the number of people who had antibodies to COVID as a measure of infection was around 40% of those tested. But the problem is, again, you have to make sure that the way that you're doing your testing is reflective of the general population if you want to try and work out what the IFR is in the general population. So if you go to specific areas, as this paper did, the dialysis unit or blood donors or a single prison, for example, then because of the nature of the people that are there, it's not necessarily reflective of the general population that you want to study. So we want to study the general population of the UK, which is slightly older, has quite a number of comorbidities, and is a high income setting. So using data from Argentina, Brazil, where people are much younger, or from low income settings like in sub-Saharan Africa, or in settings where there's some sort of change in the population. For example, if all blood donors, for example, is very different from everybody else in the population, then you can make some adjustments for that, but it's not going to be very accurate. And the other thing is, when you're trying to work out a very small number with a very high degree of accuracy, if you start to use studies that are very easily swayed by chance, for example, if you studied a population where you only took 100 samples, for example, and say you had 2 deaths. Now, by chance, if you study that population again, and maybe 2 weeks before or 2 weeks prior, you might have 5 deaths, because 3 more people have died, which isn't a lot in terms of absolute amounts, but that will massively change your infection fatality ratio from 2% to 5%, which is huge in terms of these small numbers. So the other problem with this study, and it's been through it's a really good peer review actually from a guy called Health Nerd on Twitter, but you can see that lots and lots of the studies in the paper are from very small amounts to very large amounts. They used a cutoff of 500, but some of the bigger studies were 100,000, 200,000 or 300,000 people. So what I did here is the 0.23% is the median value. So if you look at all of these studies, which range from 0% to 1.54%, what is the middle value? And that was the headline figure that's being used, which is probably a not accurate way of working this out, especially if lots of the studies within that range aren't really reflective of what you're trying to find out. So if you look at the 3 biggest studies then, which far and away take up most of the patients in this study. So there's a study from Spain that had 60,000 odd patients in it. There's a study from the UK, which is one of the largest, 109,000, and a study from the USA, particularly Brooklyn, with 11,000 patients in. And these are pretty accurate reflections of the UK general population, which is kind of what we're trying to look at. So Spain's a similar European country with a similar level of age and comorbidity, and so is the USA, to be honest, also maybe slightly more. But there's also a degree of difference in the outbreaks. So this Brooklyn study had 50% of people infected, whereas Spain and UK had 5 and 6%, because this is a local outbreak in New York, in a single borough. And the IFRs had a range of 0.4 in the Brooklyn study to just over 1% in Spain and the UK. So the other problem with this study is that it used a lot of preliminary data which isn't published. So this Russian study of 650,000 but it's not very good quality, and we don't know where it's come from, and it's not published data. So, but the IFR was very, very low. So this is slightly suspicious. So whether or not this influenced this number, I don't know. But if you look at the range here, it comes out as sort of between 0.4 and 1%. So already significantly higher than 0.2%. And this is just another paper looking at all those things that I told you about. So this graph is quite complicated, but you've got age here from 0 to 80. You've got male or female, and whether in the upper middle income setting or a high income setting, and there's 2 more graphs for lower income settings. So basically how well resourced your healthcare service is. And then if you have comorbidities, if you have no comorbidities, or if you have greater than 0, so just 1 would put you into that higher risk category. And this is a sort of modified calculation, so you can sort of see where you are at your risk, but also it gives us a closer look of what different populations might look like. So in this country, about 31% of the country has 1 risk factor, so it would be in this group. And you can see even from the age of sort of 40, your risk is 0.3, 0.7, 2, 7, and then over 70 is 4%, and over 80 is 20% risk of death if you become infected with comorbidities and you're a man. And then if you're a female, that's lower, and if you have no comorbidities, it's far lower. But the spectrum, the makeup of the population massively impacts what your fatality ratio is going to be. And that's a little bit why it's a little bit difficult then to extrapolate that to the general population accurately. But if you look at the biggest studies, you're going to get much, a lot of that data will be adjusted for, and then you're less likely to get skewed results, which is why I pulled out those 3. So the sort of working model for lots of the calculations is generally been about sort of 0.6%. So it's a little bit higher than 0.2%, which I think not many people have accepted. And between the WHO is sort of 0.5 to 1%, which is sort of looking kind of reflective of what we have here. And there's another interesting question that came up that I thought would just be interesting to cover. How do you die of COVID? And this sort of goes back to who needs intensive care beds. And who actually gets them. So how do you die of COVID? Well, essentially there's a few mechanisms, but the most obvious thing is you die of what's called COVID pneumonia. And this has been quite confusing, and I've seen this a few times on Twitter, because people are saying that this is 2 different conditions, and just because you have COVID, do you have pneumonia? What we mean, this is a clinical diagnosis of COVID pneumonia, and that means literally means consolidation, so visible fluid on a chest x-ray, which is the definition of pneumonia, caused by COVID. And we see this as a very sort of specific pattern. So again, people have low white cells, a specific type of light cells called lymphocytes. They have low platelets. They have a very high D-dimer, which is very unusual in, and very, very high, sorry, I should say. So sort of over the lab upper limit of what it can test, not the upper limit of normal, but what actually can be done in the lab. And the specific CT changes and chest x-ray changes. And in this particular situation, there's a few mechanisms of death, so what actually kills you. But the most common is, and probably by far and away, is respiratory failure. And that's because your lungs essentially fill up with fluid. What we can do in that situation, but we wouldn't do for everybody, is take them intensive care. But that's a very high risk and very impactful intervention to save your life, and it can lead to very significant trauma, and lots of people don't actually have the reserve in lots of other respects to tolerate intensive care. So be very, very unlikely to survive intensive care if you're 90 years old and you're very frail and you have diabetes and high blood pressure, and you take 15 tablets a day and you don't walk around by yourself. Then intensive care for you would be cruel and very unlikely to change your mode of death. Your eventual, whether you live or you die, but just your mode of death. And ITU is also associated with a lot of suffering. You have lines, you're paralyzed, you're sedated, you lose track of night and day. I went to a lecture once about intensive care, and he said, outside of torture, there is nothing more cause of suffering than in medicine than intensive care in the world, and that's because it employs all of those same things. And there's other things we can do in intensive care. You can be ventilated. You can also go on a sort of something called ECMO, where we put oxygen directly into your blood. But again, these are very high-risk things to do. And if you aren't going to have a very likely outcome, then you wouldn't get either of these treatments. And that's just a sensible way of using treatments and making sure that we're not doing things that are futile and cruel. So that's the commonest cause of death. But you can also die of kidney failure, because your kidneys can fail, and you can also die of heart attacks, which we saw, and clots, which we also saw. So we saw clots in legs and clots in lungs, and these were all very common. So there may be lots of stuff written on the death certificate, and most of it will be due to the underlying disease of COVID pneumonia. And I think that's really important to know, because we need to have a very clear, what's it? Any hospitals aren't full. Yes, sorry, that's very important. So actually, that's a great point. It's the point I was exactly about to make. So the point that on the questions there is, if you don't have access to intensive care, and if you don't have access to treatment, and if you don't get treatment for your heart attack or your clot, then you will also die. And you won't die in sort of natural, when there's maximum treatment, there's nowhere to go because you didn't get treatment. So one of the key principles here, exactly as alluded to here, is IFR is only true if hospitals can cope. But where local hospitals are overwhelmed, and they can't treat all the patients with respiratory failure or kidney failure, then the IFR will be much higher, because you'll be infected, but also there'll be no way to ameliorate some of the effects that otherwise healthcare could take over for example, intensive care ventilation. And therefore your mode of death will be earlier, and you will die as a consequence of lack of care. And that's exactly what we saw in Lombardy, where the IFR at one point, the CFR I should say, sorry, the number of cases, and we don't know how many people were infected in that particular situation, but the fatalities were much higher than expected because the healthcare system was overwhelmed. And also then you also get a lot of extra death from people who can't access healthcare from other aspects, which is a difficult problem. So the first thing to say here about the IFR being assumed to be 0.2% is it's probably very low, and also it's very dependent on what the local healthcare outcomes are. And as soon as you overwhelm the hospitals, then the IFR will be significant. Okay, so then there's a discussion here about the coronavirus family, which is quite interesting. So these are all different types of coronaviruses. And let me just annotate this. So we've got, this is our, what colour is it? Orange. So this is COVID. And just make things slightly smaller. And this is SARS, MERS. So this is SARS from 2003. This is the Middle East Respiratory Syndrome, and all of these ones, make that orange, are common colds. And this is important because there's lots of chat about the different coronaviruses and trying to work out what COVID might do by looking at what common cold viruses do, and SARS and MERS kind of did. And there's some interesting differences. So SARS and MERS, for example, their IFRs are probably, were much higher, were about 5 to 10%. So lots of people died. The other thing to say about SARS is we only had 8,000 cases in the entire world, whereas I think with COVID now we're over 30 million. So it's a very different outbreak. This is just a sort of graph here to kind of show the differences genetically between the 6 viruses. And this is from a really good paper which is looking at cross-immunity between coronaviruses and COVID. And you can see already, so the line number 1 is COVID. In fact, let me just annotate that as well to make it super clear. So this is COVID. Make a little red line. And then these next 2 are SARS and MERS. And then the bottom 4 are all the common cold viruses. So you can see that where the yellow is where the code sequences are the same. So the idea is that you can see the similarities and how genetically similar these 6 viruses are. So basically, just eyeballing it, COVID and SARS are pretty similar. MERS is quite similar to COVID, but not that similar. And the common cold viruses share a fair few common areas, but are much less the same than SARS. And you can sort of see that all the way down. You can see that there's not much yellow here, not much yellow here. So that's a very crude way of saying that, yes, the common cold viruses, I've messed this up now. Yes, the common cold viruses are similar, but actually SARS is much more similar than COVID, and there isn't that much similarity. So they're not that the same. So the family is quite separate genetically. I was just making that point. Okay, so the other thing is, so there's a lot of discussion in the paper about cross immunity, which is that 30% that we talked about people having pre-existing immunity. And it's useful to think about how does the immune system work? So we've got 2 types of immune system. We have an innate immune system, which is like your first pass immune system. So if a bug comes into the body, and it gets blasted by the innate immune system, which is all sorts of automatic and very quick. So it's quick but inaccurate. So it responds immediately, but in a very scattergun approach that may or may not target the specific bug. And then over time, you have a slower response, which is the acquired immune response. Slow. But it's like a sniper rifle. It's very accurate. And this is the part of the system that produces antibodies and T-cells. And then this is the system that remembers. So this is also where memory. So when you are immune to something that you've had before, this is the system that creates that specific immune response that you recall. And that's sort of the idea of antibodies, but also the idea of what we call T-cells, which is another part of the acquired immune system, I mean, generally acquired. So there's this idea of cross-immunity. And the error that the paper says is there's a significant proportion, 30% of the population, went in 2020 armed with T-cells capable of defending them against SARS-CoV-2. Now this is a slightly controversial idea, and it's useful to understand what we mean by this. So the first thing to say is all of these papers, so what lots of papers have done is they've taken people who never had COVID, so no COVID, and then taken their blood and added COVID, and then measured the response from T-cells. Now, so what that means is if you are if you've never seen COVID before, something around 20 to 50%, that's all the papers to show, you'll carry cells that will make a response to when they see COVID, despite never having had the virus. And that's because there are cells in your body that have seen other coronaviruses before, and can make a quick response, that acquired response that I mentioned earlier, because of those genetic similarities to COVID. But that doesn't mean, and that's very important, that this produces immunity, because it's in just one small part, what we call T cells, which is CD4. So it's one small part of the immune system that doesn't necessarily protect you from catching the virus. You can still catch it. It may change how infectious you are. It may change how severe the disease is. So there was a paper out recently which I was having a read of this morning, which was very interesting, but that kind of said, well, we don't know, and this is the key thing, we don't know that the reaction in the body to COVID from other T cells actually produces immunity. And it's very unlikely that it does, based on the evidence of what these cells are and what they normally do. However, if we then hypothesize about what could happen, how does that actually affect reality? Like, how does that affect our thinking? And it makes this really good point that actually we have studied what has actually happened across the world in multiple pandemics, and we've calculated lots of useful parameters about how infectious the virus is and how many people one person can infect and how it spreads through communities. So it doesn't change any of that because that's already baked in. If we already had immunity to lots of these viruses, then the way that we've modeled today is already baked into that. But basically this paper says, actually, this is interesting, but we don't know this is having any impact. It's very likely that it has any impact, but it isn't certainly anything that says, yes, these people are immune, can't carry the virus. And in terms of herd immunity, to stop one person in your group catching the virus, 70% of you have to not be able to catch it at all. And there's certainly no evidence that having these cross-reactive T-cells will stop you catching the virus. So the herd immunity threshold is unchanged by this information. Therefore, this idea that the pandemic's over because we have 30% immunity already, it may explain why some people have very different reactions to COVID, and that's quite interesting. But again, it hasn't been evidenced, and so it doesn't really change the scenario. So the idea that this error went into armored T-cell defending them against SARS, it may change their how severely unwell they get. It actually might make them more unwell, and we don't know that's the case. But it certainly doesn't change any of the calculations. And in terms of being able to infect and spread it to other people, which is the key measure, it doesn't change that. So this is not really an error per se. Okay, let's keep going on. So the next question is then, well, to work out how many people have actually seen the virus and are now immune. Now this is a big problem, number one, because we don't know that once you actually catch the virus, over a period of time, you stay immune, as in you stay antibodies that can prevent you catching the virus a second time. And we have seen quite a few now cases, although they're very small numbers compared to how many people have been infected, of reinfection. So this definitely does happen. And the IFR in this scenario, he has proposed is 0.2%, and uses this IFR to calculate how many people have been infected in the UK. Now, the problem with this is it's based on the same antibody studies, which he says aren't a very good way of working out the IFR, but that is where the paper that originally this was produced from comes from. And when you produce antibodies, you produce IgM and IgG, which are two phases, and IgG is sort of the memory. Is sort of the longer term outcome, and IgM is the sort of early production. Now, so there's two calculations in this paper that he has made to suggest that 30% of the population has been affected. The first is that if the IFR is 0.2% and we had sort of 50,000 deaths, then if you do the calculations, that comes up to be about 30% of the population in the UK. The second thing that he says is if you do antibody studies, and in the UK the antibody study prevalence is about 7%, and he suggests that if you're symptomatic and severe, you make antibodies, but if you aren't, then you don't make antibodies. So about 2 to 3 times this are people who are infected but didn't have antibodies but have other types of immunity. So that makes 30%. And by using this logic, he says that 30% of the population have been affected. However, as we've already demonstrated, and I'll come on to that, if you change this IFR, you massively change this number. And I'll show you that in a second. But the other thing to say is this idea that only severe people, symptomatic cases make antibody is not true. And the evidence from a couple of studies shows that looking specifically for IgG, which is one of the commonest antibodies that all the antibody tests look for, some also look for IgM, there's no difference in if you had symptoms or asymptomatic. And actually it may be that lots of people make more IgG initially with symptoms, and that may or may not dictate actually if they control the virus early and don't get very sick, or don't continue to spread it. So the relationship between antibody and severity of disease is not certain at all, but certainly you can't infer this number. That doesn't really make sense looking at lots of the literature. It's certainly not to that degree of certainty. So I'm just going to, so this is interesting. So then the other thing that he excludes is that children aren't really susceptible at all. So that's a very interesting question. I think people don't really have an answer to that, and for a number of different reasons. There's lots of conflicting data in the literature about children transmitting viruses or not, and there's cases of schools outbreaks where they definitely have, and childcare settings where they definitely have. But overall, some of the bigger studies have shown that this isn't really an issue. Lots of the studies have been done at times when schools have closed, which massively confounds the results. For example, this antibody test was done in Spain, the same one that we looked at, so big number, 60,000, 6% of adults, 4.4% of teens, and 3.4% of children. So not that dissimilar, but a smaller amount. But remember, schools are closed. But also you have to remember is how do we actually get tests in kids? So a swab test needs to go to the back of the nose and the back of the mouth. That's very difficult to do properly. And if you don't do it properly, you get a negative result. So that might be why we're underestimating how much kids are infected. The second thing is, how do you get blood tests from kids? And if any of you have kids and have taken them for a blood test, it's very, very difficult and not something that you would do lightly as a parent. So certainly just blanket taking blood from all the kids in an area is a very, very difficult promise. So essentially then you have to take blood opportunistically from children giving blood in other situations. And actually most of the time children are only going to give blood if they're sick, so they're more likely to be shielded or vulnerable and not be in the general population. So we have to take all these numbers with a pinch of salt. But what we have seen is lots of the antibody tests, and there's some mixed evidence that kids do play a significant role, can become infected and can transmit. Whether that's a small role or a large role, I think currently we don't really know. But I think we can't really just dismiss them as children who aren't infected, because that's certainly not what the evidence says, and as schools open again that might change. So I just wanted to return to the IFR, which is this other big supposition of why 30% of the population supposedly calculation are immune. So if we take the IFR of 0.6%, which is reflected in lots of papers and probably is a bit closer between 0.6 and 1% to the consensus of what we think the IFR probably is. But again, it's almost a meaningless number if you want to look at what the IFR is in sub-Saharan Africa. It's going to be completely different to what it is in a population like ours, where much higher population are over 65, Italy even older population, and much more comorbidities. But anyway, if you take 0.6%, that comes and use the excess death figure rather than the confirmed COVID figure, so you can again change the denominator, and you come out with 9 million people potentially have been infected so far, and that's just in England. So out of 57 million, that's 16% of the population, so way off that 30%. If you change that IFR figure to 1%, it comes down to 9% infected. So again, the susceptibility of the population is probably, it is still quite considerable. And using this as a calculation to work out susceptibility is very, very difficult and prone to lots of problems. And what I'm pointing at is there's lots and lots of uncertainty here. So to say with certainty that we should go back to normal life, I think is not very accurate. And then the last thing that he posits, and where I'll come to the end on this, I suppose, is that the pandemic is over, or it's about to come to the end. And the way he sort of comes to that conclusion is this. So this is in the first phase. Let's change the thickness again so it's a bit more obvious. So the first phase of the pandemic was this very high, steep rise. And the R here was about 2 to 3. So one patient was infecting 2 to 3 other people, and you can sort of see that that shape of curve as that increased. Now here we have the second wave, as it may or may not be called. I mean, I certainly would call it that, but some people won't. And you can see that the slope of the curve is much lower, and we think the R now is somewhere around 1.5, 1.6. So the rationale in this paper is this change in how the virus is spreading is explained purely by population immunity. But already, as we've seen from the mobility data that we looked at the beginning, that more people are staying at home. So about 30 to 40% of people are not at work or at school compared to here. So again, the interactions have decreased by 30 to 40%. People taking precautions like masks, and also we've had social distancing measures, avoiding households, avoiding travel, quarantining from countries. So there's a whole bunch of non-pharmaceutical interventions here that massively reduce spread compared to here. And just to ignore those out of hand and say this is all due to immunity doesn't stack up, but also doesn't reflect of what the reality is. And if you simply separate people, it's much harder for the virus to spread person to person. Interestingly, you can also look at the some of the footfall data, which is super interesting, in the GLA, the Great London Authority, and it shows that older people are far less likely to have gone back out on the streets than younger people. And we saw that in the data over the summer, that the number of cases in the younger patients was rising, and it wasn't in the older patients, and then it was rising in the older patients as there was a spread, which increased hospitalizations and deaths. And that's a lot of the reason why we're seeing a big disparity in how things are rising here, because people are still taking substantial precautions and lots of people are still coming out of the circulation. So if a lot of older patients continue to protect themselves, you're not going to see so many deaths, as we talked about in terms of the IFR and the age. So I would say that there isn't much strong evidence presented in this article to say that any of these things with certainty, that the pandemic is over, that we're all immune. And also there's a little bit of element of a lack of, I suppose, considering how uncertain a lot of the data is, specifically around immunity, IFR, and what the antibody responses are. And again, it goes back to those basic principles. What do you do when you aren't sure, but the risks are very high, when the stakes are very great? And it always has to be to err on the side of caution, because if you get this wrong based on pretty flimsy data, then the production for harm, the chance of harm is very, very high. And I think that's one of my biggest take-home messages here really is, when there is uncertainty, you err on the side of caution. We are very uncertain. The evidence is very weak that there's anything else that should be done or can be done. Going back to normal life, I think, frankly, is not an option. It's not something that anywhere else in the world has tried to do. Good. Okay, so let's see just a few more questions and then we'll close. So Letha's asked, we kept kids at home, so don't have enough data. I think that's a very fair point, and kind of what I made. It massively biases any study that was done during that time. So and that's probably why we don't know what happens with kids, and also the testing difficulties that we mentioned. And then she said, doesn't it take 6 weeks after a COVID infection for kids to show the Kawasaki-like syndrome? So yes, there is a syndrome called the inflammatory syndrome associated with COVID. It looks like a disease called Kawasaki, which is a disease in kids, which is essentially an autoimmune disease, and it was thought to be after a virus. Although there are some differences, and I think we had about 70 cases to date from the data in the first wave in the UK in kids. We may expect to see more. Anecdotally, a family friend of a friend actually has been diagnosed with this recently, and it can affect the body, particularly the heart arteries, which can be significant. I don't think to date we've had any deaths in kids, thank God, from this, but I'd have to go away and look at the data on that. But there's a very significant lag in exposure to when this may happen, and that's often the case with autoimmune syndrome. And Kawasaki is thought to be 6 weeks, and I don't know what the lag for COVID is, and I guess with more data we'll find out, but we don't know that yet. Okay, well that's it. So this is the paper. Do have a look at it, and any questions or any other concerns, do speak about it, and then we'll have another chat again tomorrow regarding cancer.